afternoon. I am Dr. Pushkar Rangari and I will be presenting a rare case of corneal infection following a cataract surgery in an adult. A corneal infection is a quite rare complication post phacoemulsification cataract surgery, and the most common organisms include fungal, which includes Candida and Aspergillus. Bacterial causes include Pseudomonas, Staphylococcus, Enterobacteriaceae, and Nocaria. The major diagnostic challenge is because the cultures are often negative. It requires a multimodal therapy, and the visual outcome is variable depending on the extent of involvement. We had a 78-year-old male who didn't have any systemic illnesses. He had undergone a right eye phacoemulsification with IOL implantation under local anesthesia elsewhere. He had undergone a superior phacoemulsification for which a superior clear corneal incision was visible. An acrylic foldable posterior chamber IOL was put in, and thus there was uneventful cataract surgery. On post-op day 2, the patient had taken a bath. On post-op day 3, he had sudden diminution of pain with painful diminution of vision, along with starting of topical moxifloxacin at the same center. He presented to us on post-op day 4. His presenting visual acuity was hand movements close to face with PR accurate. His conjunctiva had severe congestion along with chemosis, and the lids had significant edema. The cornea showed ring-like infiltrate which was tracking from the main wound, and there was tunnel infection along the surgical incision. The IOL was present and it had a hazy view, but it appeared stable. There was no view of fundus. The picture shows severe chemosis and congestion along with a ring-like infiltrate. A superior main port entry is seen, and a tracking ring-like infiltrate is seen along the wound. The B-scan ultrasonography was showing a stable posterior segment along with no retinal detachment, and there were vitreous echoes which was consistent with inflammatory debris. The corneal scrapings were negative for gram stain as well as culture. The culture sensitivity had reduced because of the prior topical antibiotics which he had received, and the therapeutic plan was adjusted based on the clinical response. Initially, we had given him intravitreal vancomycin and ceftazidime, along with topical therapy of fortified vancomycin, ceftazidime, and natamycin, along with oral ciprofloxacin, and ring-like pattern was observed because of his topical and systemic fungal cover was given with voriconazole. On day 7, there was extensive corneal involvement, so we modified the treatment and started him on piperacillin, tazobactam plus polymyxin B, and a significant clinical improvement was noted. A surgical backup plan was of a therapeutic penetrating keratoplasty if there was medical failure. Why did we think of endophthalmitis risk is because there was water exposure along with a compromised wound integrity. This caused an environmental pathogen introduction which we had thought, along with a culture as well as gram stain negativity and antibiotic resistance which was suspected. Because through the EVS study, we had established that vancomycin and ceftazidime is a gold standard for acute post-cataract endophthalmitis, which we had suspected at the start. There was ring-like pattern recognition which prompted voriconazole addition. The clinical response to piperacillin plus tazobactam and polymyxin B indicated a gram-negative bacterial etiology, and sequential treatment modification demonstrated the adaptive management. The complete microbiological negativity, which included gram stain as well as culture, was the most diagnostic and the most challenging diagnostic scenario. And because there is extremely rare reported cases of ring-like tunnel infection, that's why the treatment starting was quite challenging. The clinical acumen actually in this case overcame the laboratory diagnostic failure. Empirical management achieved a good visual salvage, and the patient improved up to 6/60 without any major surgery. This case has demonstrated an importance of systematic approach in a culture negative case. So what we conclude is that a post-operative patient education is quite critical for the prevention of these infections. A clinical acumen is essential for culture negative infections. Evidence-based empirical therapy can achieve excellent outcomes, and appropriate sterilization of equipments is of utmost importance. Thank you.
Thank you, Dr. Pushkar, for excellent presentation. You have added antifungal treatment on the basis of presence of ring infiltrate.
Yes,
so what is the otherwise ring infiltrate is classical of which infection basically?
So acanthamoeba shows a classical ring-like presentation along with severe headache along with it, and severe pain, unbearable pain along with it.
That's true, but you are rightly that didn't want to take the risk, and in absence of culture negativity, it was good. Was the patient diabetic?
No, sir. So he didn't have any known systemic illnesses. We also checked him for the systemic comorbidities in our center, but he didn't have any.
Anyway, very excellent result with empirical treatment, and that is a lesson to us that even if you are not getting any culture positivity or any help from the laboratory investigations, you should not get disheartened and use your clinical sense and treat these patients. Thank you.
Thank you, sir.